Hello, everyone, and welcome. I'm Rosemary Bubutu, Communications Officer at WHO, and welcome to WHO Africa Briefing. Today, we turn our attention back to COVID-19 for an update on how vaccinations are progressing in Africa. We have gathered specialists to give you the latest developments. First, some housekeeping. You can choose the language you would like to hear for the press conference by turning to the globe on the bottom right and selecting your language. Bienvenue à tous. Tout d'abord, concernant la traduction, vous pouvez choisir le langage dans lequel vous souhaitez écouter cette conférence de presse en cliquant sur le globe en bas à droite de votre écran et en sélectionnant votre langage. Joining us from Brazzaville in the Republic of Congo is Dr. Matshidiso Moeti, WHO Regional Director for Africa. I now hand over to Dr. Moeti.
Thank you very much. And good day, bonjour, and welcome to all the journalists who are joining us for this press conference. Today, we'll focus on the ongoing efforts to boost COVID-19 vaccine coverage and uptake in African countries, alongside the response to multiple other outbreaks that are challenging the continent's health responders. I'm really pleased to be joined by the Honorable Minister of Health of Liberia, Dr. Wilhelmina Jala, whose country recently became the third African country to achieve 70% primary COVID-19 vaccine coverage of its population. A huge congratulations to you and your country minister, and a warm welcome. I'm also honored to be joined by Ms. Aurelia Nguyen, the special advisor to Gavi, the Vaccine Alliance. Ms. Nguyen was instrumental Ms. Nguyen was instrumental in setting up the COVAX facility, through which 580 million or so COVID-19 vaccine doses have been provided to 53 African countries by international partners, and many lessons learned about global solidarity at the same time. A very warm welcome, Ms. Nguyen. Newly returned from the 2022 World Health Summit in Berlin, I was gratified to see the high priority the global health community is affording to the critical issues of pandemic preparedness and of resuming progress towards universal health coverage. The significant health advances being made by African countries deserve merit. However, with 11 serious disease outbreaks currently being addressed in 47 member states, and I think about 120 others less serious being addressed as well, alongside reduced COVID-19 vigilance, there is serious cause for concern and additional effort. The COVID-19 vaccine rollout is unfortunately stagnating. The monthly total number of doses being delivered into the arms of African people dropped by more than half between July and September. It is positive that we're making modest progress towards vaccinating high-risk population groups. Currently, 1 in every 3 people aged over 50 have completed the primary series, together with 40% of healthcare workers. But when overall African vaccination rates are nearly 2/3 lower than the global average, it's clear that there is still much work to be done. Critically, high vaccination coverage in populations reduces the spread of the virus and helps prevent new variants from emerging. Liberia has now reached the 70% coverage target, along with Mauritius and Seychelles, so we know that success and progress are possible. Rwanda is on target to join them very soon. We've also seen a significant decrease in the number of countries in which fewer than 10% of people have completed the primary series, from 26 at the end of last year to only 5 now. It's important to note that vaccine supply is no longer problematic. Countries are now receiving about double the number of doses per 100 people than at the end of last year. I'd like to sincerely thank the COVAX partnership for turning around a tragically inequitable situation, and together with the African Union's African Vaccine Acquisition Trust, or AVAT, assuring the steady pipeline. Unfortunately, as vaccines have helped avert serious COVID-19 illness, hospitalization, and death, people are less fearful and so also less willing to get vaccinated. Delivery strategies and systems are also being adjusted and strengthened. WHO in Africa has embarked on a raft of measures to support member states. These include assisting countries to integrate COVID-19 vaccines into other planned mass vaccination campaigns, to track vaccination among priority groups, and to carry out high-level advocacy to boost the uptake. Meanwhile, other disease outbreaks, to which I referred earlier, are also prompting a shift in priorities in affected countries, negatively impacting the efforts to ramp up COVID-19 vaccination rates. Today marks 1 month since the latest Ebola outbreak in Uganda was declared. With 64 confirmed cases, 3 of whom traveled to the capital, Kampala, and 25 confirmed deaths, the situation on the ground is rapidly evolving. The Ministry of Health of Uganda has shown a remarkable resilience and effectiveness in constantly fine-tuning the response to what is a challenging situation. The health authorities have rapidly strengthened surveillance, identifying nearly 2,000 contacts. A better understanding of the chains of transmission is helping those on the ground respond more effectively. WHO, the Africa Centers for Disease Control, and other partners are marshalling response capacities across the region to support Uganda and 6 neighboring countries. A $100 million 6-month regional readiness and response plan is being finalized, with an alert management system now fully activated in Kampala for better case detection. As WHO, we've dispersed $5 million for the response from our contingency fund for emergencies and are providing technical and operational support while helping with the national coordination of partners. We've deployed 43 technical officers to support the response at national and district levels, along infection prevention and control supplies for managing cases. We've also sent Ebola kits to set up emergency temporary hospitals. As always, community engagement is critical to building trust, cooperation, and understanding that such measures are there to protect and to save lives. Turning now to polio, it was extremely encouraging to see global leaders this week confirm $2.6 billion in funding towards the Global Polio Eradication Initiative's 2022 to 2026 strategy to end the threat, more than half the $4.6 billion target. Ahead of World Polio Day on Monday, let me stress that this global solidarity and top-level political commitment is essential to finally eradicating both wild poliovirus type 1 and the variant type 2 poliovirus. A total of 500 million doses of vaccine against the variant type 2 poliovirus have been delivered globally, with 21 African countries administering 95% of these. And among these countries, 80% have seen no further transmission of the virus. So together with the polio partners, we're also closely monitoring vaccination rounds targeting about 7.5 million children in Malawi and Mozambique to ensure that no child is left behind. Vaccination campaigns are continuing in Tanzania, Zambia, and Zimbabwe. We're also setting up an emergency operations center in Mozambique, which will provide a central location from which to coordinate data collection and the response to what is another serious public health threat. Going forward, we're working to maintain the response to COVID-19 and these other outbreaks, while also supporting the resumption of routine health services that have been disrupted by the pandemic. So again, thank you very much for having joined us today. A very warm welcome to my fellow panelists, and I look forward to our conversation. Thank you.
Thank you, Dr. Moeti. Now let's turn to the other panelists. This goes to Liberia's Honorable Minister of Health, Dr. Wilhelmina Jala. Can you tell us how the country reached such high vaccination coverage?
Good morning to all, to our moderator, to Dr. Moeti and the journalists out there. A pleasant good morning and greetings from Liberia. It hasn't been an easy road, but determination can end up very well. We received our first vaccine in April of 2021. We had to delay vaccination until June because there was that scare about blood clots from AstraZeneca. So therefore, we delayed until we had enough evidence from the global population on the safety of this vaccine. So the first vaccination started in June of 2021. And everything was going fairly well. We didn't have the kind of support from the population that we needed. But it wasn't until the Delta variant came about in early July and August, we had a high increase in vaccination coverage, especially among the educated population that was still debating whether or not to take the vaccine. But later on, with support from our partners, we began to use the traditional areas and that could help us with the vaccination and some non-traditional areas. So we use hospitals, clinics, health centers, and then we use a non-traditional site through the GSA, or General Service Agency, which was not a traditional site. And we had a lot of vaccinators go there because she was giving water, she was giving food, and she was treating people so nicely. So a lot of the people went there to take the vaccines from there. But the factor that helped us to increase the vaccination coverage was when we decided to decentralize how we were going to do the support. So our partners, WHO, USAID, and other supporting partners decided that we have 15 counties. So each county should write a plan and tell us how they were going to reach the target population in the area. So each county wrote a costed plan, and we supported them directly to implement what they have written. And because of that, each county were able to use the original technique of going from house to house, doing community engagement, speaking to the chief, trying to convince people that this vaccine was very important for their safety and for the safety of Liberia. And so from door to door, our vaccinators went to the elderly, went to the families, went all around, making sure that people were getting the vaccine. But most importantly, the vaccine cards. People wanted their cards. So with all cards, people were not coming off for the vaccines. So we worked along with the global supporters to be able to put our vaccine cards online. So it was electronic vaccine cards. Then we went to in the communities and in the hard-to-reach area, we use generators and we use photocopy machine to make sure that even in the hard-to-reach areas, people receive their vaccine cards. And at this current time, we have vaccinated 76% of the population, which is about 3.5 million people that are fully vaccinated. And 4.3 million people have taken at least one dose. We did not change vaccines. We stuck, after we used AstraZeneca, we stuck with Pfizer and J&J, so as not to confuse people. So we have people who wanted to take J&J and people who wanted to take Pfizer. But in order for your strategy to work, you need strong leadership. You need partnership. You need decentralization. You need to make a demand generation from the population all the way in every community. Get civil society, get the churches, get the religious leader, get the marketeers. We had to go everywhere to make sure that people understood the importance of the vaccine and that they should get vaccinated. And most importantly, you need support, because to reach all of those areas, to support the vaccinators on time and as supervisors, you need the proper support. And you can't forget, or now we're trying to integrate it into routine vaccine care. But we took that opportunity to ask about family planning, to ask about TB, to ask about HIV, to ask other questions while our vaccinators were in the field. So we used that opportunity to get other information, how people were faring as they came out for the vaccines. Thank you.
Thank you very much, Dr. Jala. Now over to Miss Aurelia Nguyen from Gavi, the Vaccine Alliance. What is Gavi doing to ensure that the continent continues to access COVID-19 vaccines?
Thank you so much, Rosemary, and good morning, good afternoon to colleagues and friends in the media, and my thanks to Dr. Moeti and WHO AFRO for being able to join you today. Thank you to the Honourable Minister, Dr. Jala, for sharing your insights. Really remarkable work being done in Liberia. I want to start my remarks by, first of all, celebrating the progress on the continent. You've heard, I think, some good highlights of that. And also to say that overall, at the beginning of this year, there were 28 countries that are covered by the COVAX Advanced Market Commitment that were below 10% vaccination coverage for COVID-19. And that meant millions were still at risk in terms of severe disease, death, and infections, particularly the high-risk populations of healthcare workers and elderly. And since the beginning of the years, 22 countries have moved past this milestone. We've got Burkina Faso and Malawi that have become the latest countries to do so. We have Mali that is set to cross the milestone of more than 10% coverage in the coming weeks. And in this group, many countries have more than doubled their coverage rates, some much higher than that, we've heard. So across the continent, Côte d'Ivoire, Ethiopia, Tanzania, Zambia, all reaching 30% or higher. Really an amazing accomplishment that I really want to give recognition to, especially given all the other really vital routine immunization work that's happening in parallel. And really this progress is possible with the incredible efforts of the healthcare workers, the communities, civil society, the partners, and the governments. And COVAX has really been there every step of the way since February 2020, when we 21, when we shipped our first doses to the African continent. We've now supplied 670 million doses. We've provided tailored support with our partners to increase the uptake with the technical assistance, the cold chain equipment, the training, the support, and very importantly, the awareness campaigns. So we will continue to collaborate. There is still more work to be done. We just heard from Dr. Moeti. It feels like to some COVID-19 is no longer a threat, but this pandemic is actually not over. We still have more than 250,000 people on the continent that have lost their lives so far, and we need to make sure that we keep any increases as low as possible. We're focusing at COVAX on helping countries vaccinate as many people as possible. We have enough doses to go around. We're especially determined to make sure the vulnerable groups are protected. And so elderly healthcare workers, primary series, but also boosters. And this is the only way that we're going to be able to ensure that lives are saved and that the health systems hold strong if we have a new variant or surge, which is still very much something that could happen. And we're doing this not just, of course, because it saves lives, not just because it protects health systems, but also because I think we really recognize that there are very many pressing health challenges at the moment. And we hear this consistently, that there are many things that we need to be looking at. We've just heard the outbreaks of polio, there's outbreaks of measles, cholera, all of those are a sign that the impact of the pandemic on the routine immunization system and all the other essential health services is important and has been and makes the threat of other outbreaks all the more real. We have the outbreak of the Ebola Sudan species in Uganda, as has also been highlighted. So we really look to governments, to communities to continue to lead the way. We've seen, and we've just heard from the Honourable Minister, some of the amazing innovations, the community-led, the civil society-led work that has helped with increasing awareness and vaccine demand. Gavi has made 25 million additional funding available specifically to CSOs to make sure that these efforts are supported. So we know that progress is possible. We've seen it. We really want to make sure that we carry on with integrating COVID-19 vaccines with other health priorities. For example, in Tanzania, integrating campaigns between COVID-19 and polio vaccination efforts to really make sure that we push on these priorities together. The Gavi Alliance has been focused also on the recovery of the routine systems, and this is the foundation of our work, strengthening African health systems, working with our partners, including the African Union, on plans to enable also for the long run sustainable manufacturing capacity on the continent. Finally, we're going to continue to work with our COVAX partners to make sure our country's needs are met in the face of existing and new challenges. This week, Gavi has signed an agreement with Moderna for up to 100 million doses of variant-containing vaccine in 2023, so that all countries, and most importantly, lower-income countries, have an equal choice to use the vaccines that are available globally in their booster programs where that's appropriate. So with that, thank you so much for your time. I really look forward to answering your questions.
Thank you very much, Ms. Gwen, for all this information. Now that we've heard from all our speakers, we will open the floor for journalists to ask questions. We have additional experts from WHO on hand to respond to some of the questions if needed. They are Dr. Mojiro Ndutabe, Polio Rapid Response Team Coordinator, Dr. Jamal Ahmed, Polio Coordinator, Dr. Fiona Atuebwe, Regional Vaccines Introduction Officer, Dr. Tierno Balde, Regional COVID-19 Incident Manager, and Dr. Patrick Otim, WHO Africa's Incident Manager for the Ebola outbreak in Uganda. So we would like to recall that this is a media briefing, so we ask all the people in attendance to note that only journalist questions will be answered. Dear colleagues of the press, please use the question and answer function on the Zoom application to ask your questions. Please also note that even if you want to ask a question live by raising your hand, you need to take the time to introduce yourself and your media outlet in the Q&A function in the Zoom to be given the floor. So now let's take our first question. So this one is from Mike of the Medical Media Services, and this one goes to Fiona. How many African countries have so far been able to vaccinate more than half of their eligible population against COVID-19? So
thank you.
Dr. Atuebwe, yeah.
Thank you very much, Rosemary. So we have only 8 countries that have made it beyond 50% coverage so far for the COVID-19 vaccination, and these are Tunisia, Botswana, Cabo Verde, Morocco, Rwanda, the country we are celebrating today for crossing over to 70%, Liberia, Seychelles, and Mauritius. So far we only have 8 countries that have vaccinated more than 50% of their total populations. Over to you, Rosemary.
Thank you very much, Dr. Fiona. Now I have a question for Dr. Jala. Honorable Minister, can you perhaps add to this as to what was the magic bullet that allowed Liberia to vaccinate more than half of their population?
The magic bullet was decentralization, making sure each county run their own vaccination campaign, and the participation of all the healthcare workers and the vaccinators, and the support from all of the partners, USAID, WHO, and the other partners, and making sure that the vaccines were available. That's key to success.
Thank you, Honorable Minister. Now over to Ms. Nguyen. Please, can you tell us what do you think is driving up vaccination rates?
Thank you very much. I think there's been, I think, a very, very strong engagement from countries, and we see that really, as there is so much population movement as well, I think there's a recognition that there has to be high immunity. But also, I think having African countries increasing their coverage with homegrown, tailored approaches, a little bit like the ones that we've heard in Liberia, has really helped drive up vaccination rates. We've seen great tactics, for example, strategically addressing false news and rumors around COVID-19 vaccination using local community sensitization programs. We've seen in Niger, women-driven mobilization campaigns in rural areas, door-to-door vaccination. Again, in Niger, vaccination teams that are deployed around nomadic corridors. An example from Djibouti, using alternative transport to get vaccines to really hard, remote areas of the country, using donkeys and camels. Vaccination sites that have apps in Nigeria to find your closest vaccination site. South Sudan and Somalia, there's been a very strong mobilization with religious and community leaders, mobile vaccination sites, using radio stations. So we see many, many examples of this type of innovation, and very much sort of locally adapted situations that I think have helped move that. And as I alluded to a little bit previously before, as we look forward now, making sure that we think about integration is a really important theme. So the example I gave of Tanzania, of COVID-19 and routine immunization for polio, I think this is going to help keep driving the increases. It's also going to help ensure that it's not one vaccination program to the detriment of the other. As we're seeing, it's really the whole routine immunization that needs to move together. Thank you.
Thank you very much. We have received a question from Paul Adepoju of The Lancet. I will first go to Dr. Moeti and Ms. Nguyen for answers. How far is the current state of COVID vaccination from the initial projection regarding the rollout? And what threat does the attention to other outbreaks pose to COVID vaccination rollout? Moreover, what is the situation of COVID vaccination in Eritrea? And what can we infer regarding the need for vaccination, even though the country is the only one not immunizing its people? So, Dr. Moeti.
Okay, thank you. Thank you very much. I think it's clear that we are far from the original targets that have been set as far as coverage with COVID-19 vaccination in the African region is concerned. At a certain point in time, early this year, we were saying we'd need to ramp up 7 times the rate at which vaccination was happening in the African region. So I think we're acknowledging, looking at the number of countries that have reached the 70% coverage of their population, and even those that have accelerated coverage of the most vulnerable groups, that there is clearly a need to speed up and to do better, faster. I think what the minister outlined as the drivers of their progress, the rapid progress in Liberia, are some of the things that really need to be promoted and that we are working on promoting, adapting to the local context in different countries. We are supporting countries to carry out micro-planning at the subnational and the local level so that we can understand locally what is needed, what needs to be done, who is going to do it, what are the resources needed, and what's the strategy that's needed. I think if that is combined with using tools to support people acquiring their connection with the vaccination system, still carrying out some campaigns. I agree very much with the need now to explore opportunities for integrating these with other services, ensuring that the integration helps us to reach the highest priority groups that we'd like to reach, and finding ways to learn how to identify these groups. So even as we integrate, we make sure that we're reaching the most vulnerable people first. I've seen in some countries where there is a high HIV prevalence and well-established programs by communities living with HIV, for example, that these offer opportunities to integrate COVID-19 vaccination services to one of the groups that are vulnerable. We need to learn more about how elderly people are having access to primary care in Africa, how services for chronic diseases that make people vulnerable are being organized. These we know do not have distinct services. So it's very much, I think, integrating at the primary care level, looking at where people are managing diabetes, hypertension, non-communicable diseases. In a way, I believe this will help us to accelerate more structured attention to these hitherto rather neglected diseases, which have shown themselves to be so important. So I think it's very much a matter of innovation and learning. We're working to catch up is the bottom line in relation to our initial targets and even what we had projected needed to happen at the start of the year. Of course, the threat of other outbreaks, we need to see how to do all this at the same time. That is part of the work of resuming other services, and where there are opportunities to do this together, particularly if there are outbreaks that need vaccination as an intervention, then we need to be exploring these to the degree that it's possible. With regard to Eritrea, a country that has not started vaccinating its population, we continue to advocate with the Eritrean authorities on the need to initiate this vaccination of their population, working with the UN partners at the country level, the UN country team, and through the WHO. And we anticipate that now that vaccines are no longer a problem, now that the country can address their concern about equity in using the vaccine to cover their whole population, that really is no longer a problem. And it's now a matter of helping to plan how to carry out this rollout in that country as well. Thank you.
Thank you, Dr. Moeti. Ms. Guyenne, can you add a few words? You have a few things to say to...
Thank you so much. And I think Dr. Moeti has been giving very, very helpful information. So maybe just a few thoughts to complement in terms of, I mean, at the moment, the coverage in healthcare workers in the countries who report in the WHO Afro region is 53% in terms of those who have completed their primary series, and it's 31% of older adults in terms of those who have completed their primary series as well. And I think that's really the first priority. And it's been so, I think, from the start, and it still is today, in terms of making sure that, yes, the pandemic has evolved over time, but I think that has to remain a very important focus. And actually, I mean, there is some good news here in the sense of in lower income countries, generally, we're seeing that the coverage of healthcare workers is actually among the highest in the world. So I think really just to take a moment, I think to celebrate, I think the remarkable result here in terms of protection of healthcare workers, recognizing there is still, I think, some way to go. But what we're seeing is the coverage in the elderly is way below average. And so really making sure that we develop the programs, as Dr. Moeti was highlighting, and particularly not just staying at primary series, but also enrolling booster programs, I think is going to be really an important piece for us to focus. I think it's really where we're going to save the most lives, and it's also going to be the part that helps protect the health systems overall as we respond to other threats.
Thank you. Please, Honorable Minister Jala, can you also tell us a few words about how Liberia is addressing the threat, if any, that the attention to other outbreaks are posing to COVID vaccination rollout?
Because of a little bit of neglect of the routine or services, measles outbreak. So we are now, using the same vaccinators to make sure that they vaccinate on measles. Even during the outbreak, while we were vaccinating, we were able to introduce the polio or vaccines again, and then we were able to introduce typhoid vaccines. So as outbreaks or other things come about, while COVID vaccine is being rolled out, we are using the opportunity to make sure that we are not forgetting about other outbreaks that could possibly threaten at least the young kids.
Thank you, Dr. Jala. Next question is going to Dr. Moeti. This question is from James Mashaya Chege at Reuters in Johannesburg. Experts and health workers talk of a major undercount of monkeypox cases in Africa because contact tracing and testing is often not carried out. First, how big is the undercount? And second, do you factor that in when considering funding and supplies for countries in the region coping with monkeypox? And third, does WHO think the statistics they use or published are undercounts? Dr. Patrick Otim, also you can help out or complete Dr. Moeti's answer. Dr. Moeti?
Okay, thank you very much for that question. So first, is there undercounting? I think yes, no doubt, but I do believe that with the type of awareness raising, training on the case definition, how to recognize a case of monkeypox, even if it was not possible to confirm with a test, it's been possible to expand if you like, the correct identification of cases and to reduce the undercounting. I remember at some point where in the Democratic Republic of the Congo, for example, the clinical recognition of cases was many times higher than the confirmation through testing. And that was because of all the awareness raising, training of healthcare workers, making sure that they understand, they know the case definition, and they can recognize what is probably a case. For lack of access to testing supplies, it wasn't possible to confirm these. I believe this has progressively reduced. We did acquire some testing supplies in some of the countries. Certainly the level of sensitivity of the healthcare workers has increased, but there is no doubt, as happens in many outbreaks, that a certain proportion of the cases will not be counted. When we plan for mobilizing resources, we use both the confirmed cases and also the probable cases. And the fact that part of what you do in managing an outbreak is to go looking for cases. So you are likely to find more cases and therefore have to intervene. So we don't raise money just based on the number of cases that we have actually counted. So that is somewhat factored in. And it's very important, I believe, that we continue to, particularly at the most peripheral level among the healthcare workers, raise the index of suspicion, meaning their understanding of what is probably a case, so that these investigations and confirmations can be done and the response can address the entire risk in a country. So strengthening the surveillance systems right down to the primary care level, to the most peripheral level, is one of the most important investments that can be made. Then, of course, as I've said before, ensuring that communities also understand. People, when they see themselves or their neighbors or family members what resembles the illness that have been described, also contact the health services. This is the way in which we can detect all the cases. So my colleague might like to provide additional information in response to this question.
Dr. Otim, please.
Thank you very much, Rosemary, and thanks, Dr. Moeti, for ably addressing most of the elements of this question. I think I'll just add one component. In terms of the transmission in Africa, when we look at it, we have 13 countries in the continent that have reported cases. Out of the 13 countries, we know that there are countries that have previously, prior to 2022, reported monkeypox cases. Now, when you look at the new countries that reported cases this year, there is active case search and case-based investigation of all suspected and reported cases going on. So we are quite sure definitely that in those countries that all the cases that have been identified are being counted. And most of these countries do not have many cases, with the exception of Ghana, that has had over 100 cases confirmed. And Ghana has significantly scaled up their surveillance and have been doing investigation and testing for all suspected cases that are reported. The second category of countries then are those countries that have had cases previously, and there's the biggest, most affected being the DRC that Dr. Moeti has mentioned. And in DRC, then there have been a significant shift in terms of the surveillance approach that was being implemented. We need to know that DRC has been dealing with the problem of monkeypox for a very long time, and it has been one of the priority disease conditions, and they have been using a syndromic surveillance approach to report and investigate cases. And as the transmission increased across the world, there was a change in their strategy to try and increase the identification of cases and testing. And I would agree that a country the size of DRC, there are definitely challenges in terms of how much testing we can be able to do and access to facilities, but there has been significant improvement in DRC, in Nigeria, and we are currently working with these countries. We had missions to Ghana and Nigeria in the last 2 weeks, and we are having another mission of experts to DRC and the Central African Republic, looking holistically at the monkeypox response and trying to see how better we can improve in terms of both the investigation and confirmation of cases, but also in terms of the management and planning for potential use of vaccines when they become available. Thank you.
Thank you very much, Dr. Otim. Now we have a question from Sade Oguntola from Nigerian Tribune. This one will go over to Dr. Jamal and Ms. Nguyen. The wild polio virus is coming back strong without control. In the next 5 years, do you see this taking us back to the period before such countries as Nigeria were certified free of polio? Dr. Jamal Ahmed?
Yeah, no, thank you so much. I'm just turning on my camera. Just first to remind, I think, everybody that the virus that we are seeing in Mozambique and Malawi was imported from Pakistan. And before that, for 30 years, and close to 30 years, there has not been any wild polio virus in this country, which means that we have had many years of many generations growing up with nothing to worry about wild polio virus and paralysis, and families growing up in peace. That also highlights, heavily the work that was done over the years. This new outbreak was detected in February, and the response efforts have been ongoing since then. More than five rounds have so far been implemented, and we do not foresee, this getting out of hand in that geography. And we will knock it out hopefully by the beginning of next year. We should be back to zero wild polio in that sub-region. Malawi has only reported 1 case. Mozambique has so far reported 7 cases. I think the countries have been at the forefront in pushing forward, and with the eradication effort, there has been a lot of boost in terms of investments in surveillance, in local response capacity. So we anticipate that we will find every virus that is circulating in there, and we will hopefully deliver on zero wild polio in Southern Africa. In terms of the greater risk, the reality is, as long as we have wild polio somewhere in the world, there's always the risk of reimportation and then the reestablishment of circulation. And that's why the whole outbreak response processes are to make sure that we detect such kinds of importations if they happen, and respond as aggressively as possible so that those chains of transmissions do not get established within the African region. So that is the process, and hopefully we will address it. I'll stop here and maybe hand it back to you. Thank you so much.
Thank you very much, Doctor. So, the Honorable Minister Jalad from Liberia had to excuse herself as she had to attend another meeting, but we thank her very much for her presence and all the inputs that she was able to provide. Now, the next question will go over. Please, Ms. Nguyen, if you wanted to add anything on the polio question, polio virus coming back.
So indeed, I mean, I think it is very unfortunate in terms of the cases that we're seeing of circulating vaccine-derived polio virus type 2. It's rare. I think these challenges are something that remain in countries. I think maybe also to put it in the context that over the last 3 decades, the polio cases have reduced by 99.9% with the commitment of the polio program, the communities, the governments, the donors, the partners. So I think we have to make sure that we very much stay focused in doing high quality vaccination campaigns and on having very strong surveillance to make sure that we don't start to see some backsliding. And I think these cases demonstrate that there is indeed a continued threat to children everywhere. It is something we're very much treating continually as a public health emergency. So with the combination of a need for continued investment, and that's in the primary healthcare systems, in the immunization systems, and making sure that we really see where there are pockets of vulnerable populations that may have not been protected. That's really going to be the key in terms of not having a further resurgence. And it's very much the focus of the work that Gavi, as one of the partners of the polio partnership, is doing. Thank you.
Thank you very much, Ms. Nguyen. Dr. Moeti, can you add a few words on the polio?
Yes, I just wanted to actually say that I think to say that while polio virus is coming back strong and out of control, just needs some contextualization. And my colleague said clearly that these were imported cases in Southern African countries where we have not seen wild polio virus for a long time, and there's been a very strong response. Secondly, of course, that and the vaccine-derived polio cases we are seeing just point to the need and the importance of routine vaccination against children, and really finding those children that have not been vaccinated, so-called zero-dose children, and focusing on making sure that these children are vaccinated. That's a very important part of the strategy, as well as continued routine immunization for everybody else. So there's a very strong response to this wild polio virus outbreak that is being seen now, and we are very hopeful that it'll be contained. It's important, I agree, but I think I think we need to put it in its proper perspective. It's something where there's a very strong mobilization of partners. I do not yet believe that it's out of control. But the fact that we're seeing also polio virus being detected in systems in wealthy countries, Western countries, means that we need to continue with this surveillance, with effort, and with vaccinating children so that whatever is going on, they are not vulnerable then to being infected and to being paralyzed, which is what we want to stop. Thank you.
Thank you very much, Dr. Moeti. Next question will go to Dr. Patrick Otim. This question is coming from Lisa Song, a reporter at ProPublica. For the Uganda Ebola outbreak, is there any information on the hometown or location of the index patient?
Thank you very much for the question. For now, we do not have information as to the hometown or location of the index case. But what we are dealing with is then that the epicenter of the outbreak remains within Mubende, And in Mubende in particular, we have two most affected sub-counties of Madudu and Chiruma, where most of the cases have come from. So there are three levels of investigations ongoing. The epidemiological investigation, trying to link the different chains of transmission, trying to identify who could have got infected from who. And the Ministry of Health has put in significant human resource, and we have been supporting them on this line of investigation. It is still ongoing. The second one, in terms of the virological investigation with the genome sequencing that was being done to try to identify whether this was imported from somewhere else. And we saw in the previous press conference when colleagues from the Uganda Virus Research Institute said that the virus was closely linked to the one that was circulating in Uganda in 2012. So we know that the virus could be within the ecosystem. The third one, which the Ministry of Health in Uganda and partners from the Ministry of Animal Resources are doing now, is the ecological investigation. They have deployed a team that has gone to the mines in Chiruma to try and identify the bats that are there and try to see if they can isolate any virus. So we will then, at the end of this whole exercise, triangulate the information from the epidemiological arm, from the virological arm, and then from the ecological investigation to see if we can be able to pinpoint. But it is still early and the investigations are ongoing, and we are really grateful to the Ministry of Health and the different One Health partners on ground who are coordinating this effort to help us better understand where this particular outbreak could have originated from. Thank you.
Thank you very much, Dr. Otim. Dr. Moeti, do you have anything to add, any information to add on this question about Ebola? And we also received another question. The Director General has said he's concerned about the spread of Ebola in Uganda, as the latest 8 cases were not contacts of known patients. Can you also shed some light on this situation, please?
Yes, thank you very much. No, I don't have anything to add to what Patrick has said. I think in terms of the concern expressed by the Director General with regard to the known contacts of the cases, I mean, of course, any outbreak of Ebola is a major public health concern and problem, and we share that concern, as does the government of Uganda, and therefore, it is very important to do the contact tracing. What we do know is that, in fact, once the information was looked at all together, most of the cases, including the cases that were mentioned by the Director General, if we look not so much at sort of Go data information that was publicly available, but at the case data of the individual cases, it has been possible. In fact, we were assured this morning to trace these cases to known transmission chains in Uganda. What we do know is that the government has responded once the outbreak was identified, working with partners very much to deepen the contact tracing, epidemiological surveillance of what's going on in Uganda. And we see that a big effort has been made by the government with a lot of commitment, with support from ourselves and from other partners to investigate all of the cases. And these 8 cases, which were initially not linked to previous cases, have since been linked to known cases or health facilities where cases were identified. So the situation is, of course, of concern. Most of these cases are, in fact, connected to known cases or health facilities where cases were there. And what is very good is that the surveillance is being deepened, is being expanded, because the objective is to find out exactly what happened with each and every case and ensure that we are tracking, identifying, and intervening with all the transmission chains that are going on.
Thank you very much, Dr. Moeti. Next question is from RFI. It will go to Dr. Atuebwe. Yesterday, WHO announced also that there was a shortfall of cholera vaccines due to global tensions. What is the current situation? Will the WHO be able to meet demand in Cameroon and also in the DRC, where over 300 cases of cholera have been reported?
Thank you very much for that excellent question. So unfortunately, after years of declining numbers, there's an upsurge of cholera outbreaks around the globe, and of course, we know majorly in Africa. But given acute vaccine shortages, the International Coordinating Group on Vaccine Provision is temporarily suspending the standard 2-dose vaccine regimen in cholera outbreak response campaigns, using instead a single-dose approach. And this temporary use of a 1-dose strategy will allow more people to be vaccinated and provide them with protection in the near term. So means we get more doses for DRC and Cameroon, as has been asked. However, while vaccines are still a critical tool in the prevention of these cholera outbreaks, they are not the only tool we have. Cholera can be prevented with access to safe water and sanitation, and also treated with oral rehydration or antibiotics for severe cases. The reality is that many people do not have access to this. So all countries are eligible to request for the vaccines from the global stockpile to respond to the cholera outbreaks. The vaccine stockpile can also be used for preventive vaccination in endemic countries. However, countries cannot access requests for access to these oral cholera vaccines stockpile to build their own stockpiles. So given the announcement that was made yesterday, we do know and hope that Cameroon and DRC will be able to access more vaccine doses.
Thank you very much, Doctor. I have a follow-up question. A follow-up question for Dr. Moeti from James from Reuters. Does the WHO think that the statistics it uses or publishes are also undercounts?
Thank you very much. I think that's a very broad question, which is almost not possible to answer, because following an outbreak that's currently going on is a process of following up where the numbers are increasing because the outbreak may be spreading, and therefore the process of counting is also following those contact tracing processes. I mean, for example, what I can say about the surveillance in the Ebola outbreak in Uganda is that the percentage of contacts that have been traced and follow-up has increased hugely from the start of when this outbreak investigation was started. So we are managing to be following up virtually all the contacts of all the cases that we have discovered, that have been discovered so far. So the contact tracing rate is in the 90%, which means really the rate of undercounting, the degree of undercounting is inevitably there because the situation is evolving dynamically all the time, but we don't think it is that severe. So it's very difficult to answer a general question like, does WHO publish underestimated surveillance, because we're always dealing with situations that are evolving and changing, and that is the very purpose of surveillance. But what we try to do is to minimize the degree to which there is a discrepancy between what we publish and the real situation, which is permanently changing, by strengthening the surveillance tracking to the degree that it is possible. So is it possible to be reporting on 100% of all the cases that are occurring all the time? I don't think so. But I think in this case and in many cases, we have found ways to improve and increase surveillance systems so that we try to track to the degree that it's possible. And there are ways of estimating the degree to which we might be undercounting in the reporting.
Thank you very much, Dr. Moeti. I'm turning over to Ms. Aurelia Nguyen also to give more information on the cholera vaccine situation and probably what Gavi is doing right now.
Thank you very much. And yes, just to say, I mean, it is extremely concerning in terms of the situation. I think also highlighting the knock-on effects of the pandemic, climate change and other factors that impact access to clean water. One of the things that I wanted to highlight is that I think the risks that we're seeing really show why healthy vaccine markets are so important in terms of making sure that we have the right supply of vaccines on hand when demand moves, and increases. And this, we've been working very closely with the lead manufacturer who's been producing at risk with support from Gavi. But over time, what we really need to have is a longer term predictable market so that we can start doing not just the reactive campaigns for outbreaks, but preventive campaigns, because that is ultimately what is going to help to have not only an impact on preventing outbreaks, but also on making sure that we have a big manufacturing base, including, if possible, in Africa, for example, so that when there is a surge in demand, we can rapidly respond to it. So this is really, I think, an important lesson and something for us to think about in terms of opportunities, not as well as, of course, the risks that we're facing now.
Thank you very much. Now we have a question from going to Dr. Fiona Atuebwe. The question comes from Paul Adepoju of The Lancet. What is the latest regarding Ebola vaccine trial in Uganda?
Thanks again. So the WHO announced last month that it started international consultations with vaccine developers to identify vaccine candidates against the Sudan Ebola virus that could be tested in randomized clinical trials in Uganda. There are several vaccine candidates in different stages of development that look promising, but more data is needed to confirm their safety and efficacy in humans. So as a result, vaccine candidates must be now taken through the clinical trials in Uganda to ensure that they work and are actually safe. So right now, an independent WHO expert group is reviewing the evidence and will advise on which vaccines are to test first. And also clinical trials, given that they are delivered following a rigorous scientific process, the trial protocol is reviewed by a number of different groups, and approval will be required by the WHO Research Ethics Review Committee also, the Uganda National Council of Science and Technology, the National Drug Authority, which is the regulatory authority in Uganda, before these vaccines can arrive in the country to start trials. These processes are currently happening and progressing very quickly, but they do take time and we cannot skip any of these steps. So right now, the Uganda authorities are reviewing the protocol, WHO simultaneously also reviewing the protocol and approving, doing consultations on which vaccines get into the country first. As soon as the protocols are approved, the vaccines get into the country. On the ground, all the other processes are taking place, having the scientists, the scientific teams being put together, the cold chain being put together, and the community engagement processes also to start very soon. We hope that all this can take place as soon as possible in a few weeks, and getting sufficient supplies to is of paramount importance because we saw what happened during COVID, and we would want to make sure that this does not happen again. In the meantime, even after the study, even when the study begins or after it begins, the usual safety efforts and measures to prevent Ebola must continue.
Thank you very much, Dr. Atuebwe. We're coming to an end to this virtual press conference. Thank you to all our experts. We will now turn to our panelists to hear their final words. You have 1 minute each. We will start with Ms. Aurélie Nguyen.
Thanks so much. I really appreciate the opportunity. And just from my end, I think to highlight where we began, which is really the incredible progress that's being made on COVID-19 vaccination, to show that it is possible with the efforts of the governments, the communities, and everyone who supports them to administer more vaccines than has ever been administered before in history. And just to say that from a Gavi perspective, we're really here in support of both routine immunization, outbreak response, and also we look to future activities like regional manufacturing, where we can really make sure that our commitment to having a long-term system in Africa where we can have everything we need to have the health systems protected and ultimately people protected. Thank you.
Thank you very much. And over to you, Dr. Moeti, for your final message.
Yes, thank you. I think I too would like very much to recognize, using the Liberian experience as an example, that with a determined government and a strategic approach and a mobilized community and getting the tools out into the field, decentralizing, working with civil society, working together as partners, it is possible to make this type of progress and see what we are seeing in Liberia. And one can only then encourage our other member states and partners to work together to mirror this, adapted to the local context in different countries. As I've said, and I say all the time, what's vital is to find and the best way to reach people, help them, convince them, and ending by saying that the most vulnerable groups, those people that could become seriously ill, could die, and we have seen die in previous rounds, are the ones that we need to target now. So we need to be smart about finding our elderly, supporting them. Sometimes they're not digitally connected, and finding ways in which we can reach them through trusted intermediaries. I think this is very much possible. And I just finally to thank Ms. Nguyen, thank the COVAX and other partners for their consistent support to vaccination of populations in Africa. And of course, thank our colleagues in the press for the important role that they play in informing people, decision makers, and communities about the importance of this work. We'd like to protect African health systems so that we can progressively resume the other services that are needed, including routine vaccination and reaching unvaccinated children, and do it all together with the work on COVID-19. So thank you all very much for the help that you are providing to that.
So thank you very much, everyone, for your attendance. Thank you to our panelists, and goodbye.